here's the twist.
Please welcome to the stage Axios congressional reporter Steph Kite.
Hello, everyone. Thank you so much for joining us this morning as we examine the risks, regulations, and opportunities shaping the evolving GLP-1 landscape. I'm Steph Kite. I'm a congressional reporter for Axios and co-author of our Hill Leaders newsletter, which you can sign up for by going to axios.com/newsletters. I want to thank our partner this morning, the Partnership for Safe Medicines, for making today's conversation possible. As GLP-1 medications continue to transform healthcare, Congress is considering how to expand access, strengthen oversight, and encourage innovation while keeping patient safety at the forefront. To help us kick off this conversation, please help me welcome Representative Rudy Yakym of Indiana. Welcome, Congressman. So not a busy week in the House, right?
Nothing going on around here, right? Just a slow week.
Well, before we dive into the GLP-1 conversation, I did want to get your read on there will be a vote today on a budget resolution which would start the reconciliation process again. How are you feeling about that vote? Does this get done today?
I think it does get done today. I mean, as we saw last week, the House is back to governing. We passed a rule in the House last week, and we're actually moving bills across the floor. You know, it's a different environment in the House after you've been shut down for a few weeks, and you pass a rule and you walk into the cloakroom. It's kind of a scene out of an MLB baseball championship series where there's popping champagne and spraying champagne all over the cloakroom. You're like, what happened? It's like, well, we just passed a rule. We're back to governing again. So it's a great feeling to be doing that. And I do think this gets done. I mean, ultimately, we need to fund our military and do some other things that the administration's asked us to do. So I do believe that this is something that'll get done today.
Well, we will see shortly. All right, so to GLP-1s, GLP-1 use has exploded. Gallup found that 1 in 9 Americans now report taking one, and that's up from just 3% 2 years ago. You introduced the Safe Drugs Act in response to part of that boom. Can you give us the Axios smart brevity? What's the problem that your bill is trying to solve?
What we're really attempting to do is to create parity in the drug space. There should not be two worlds in medicine. We should have one consistent standard for safety, whether you're big pharma or a compounding pharmacy. So what this bill attempts to do is to say you have to live by the same standards. You know, for example, if you're a compounding pharmacy and you're making drugs at an industrial scale, you should have to live by the same health and safety standards as big pharma. When the Hoosiers that I serve take a medication, they expect that the medication they're taking is going to be safe. And they expect that the standards are going to be consistent no matter who you are and no matter where your drugs are manufactured.
And so how does your bill specifically do that? Can you talk about the impact it would have on these compounding companies?
Sure. What this bill simply does is it says that if you're a compounding pharmacy and you're making drugs at an industrial scale, for example, you're making more than 100 medications and sending them out across the country, you have to live by the same standards as a traditional manufacturer. There's a couple of very simple things that this bill requires. It elevates the standards so that if you are in the manufacturing space, you have to have an FDA inspection before you begin manufacturing, and you have to have that same inspection every other year, just as you would a traditional pharmaceutical company. You also have to disclose where your original source materials come from, just like everybody else does. So it's a disclosure requirement as well as an inspection requirement, again, just simply to create parity with the traditional pharmaceutical companies.
And where does this bill stand today, and what's the path forward?
We've introduced it in the House. We have it's a bipartisan bill in the House of Representatives. In the Senate, not only has it been introduced, but it's also headed for a markup in the Senate. So I'm simply just working with my colleagues here in the House to see if we can get this bill called up for a markup.
Right. And so you mentioned your bill would add requirements for some of these mass compounding companies who mass compound GLP-1s. Over safety concerns. But for many people, compound drugs are the only way they can afford to access some of these GLP-1s. What do you tell people who worry that a bill like yours would make it harder or even impossible for them to get a GLP-1?
Well, it shouldn't be harder or even impossible. And the reality is that this bill is not a pricing bill. This bill is a safety bill. Americans expect that when they take a medication, the medication they're taking is going to be safe. And the cost of that safety is baked into every dose that you consume. And so my belief is you should have parity in how drugs are manufactured in terms of the safety requirements for those drugs. And if that's your core belief, you really have one of two choices. You either have to lower the standard for the traditional manufacturers, or you have to raise the standard for the compounding pharmacies. My belief is, as it relates to health and safety in this country, we should be raising the standards for safety. Americans just simply expect that. So we should be raising those standards, not lowering them, and that's what my bill tries to do, is to create that parity. Again, not a pricing bill, but a safety bill.
Well, certainly, if there are more steps for some of these compounding companies to go through, it could lead to less accessible drugs, right?
There is a cost to safety, plain and simple. There's a cost to safety. I don't think this is anything that's crazy. I mean, the ability to just simply pass an FDA inspection before you start manufacturing, I mean, that's a basic fundamental requirement. The requirement to simply disclose where your source materials come from, this is a disclosure. When it comes to disclosure, you don't have to do a whole lot of additional work. You just simply have to say, here's our source materials, here's where they came from, here's how we got them. So it's a pretty simple bill as it relates to the disclosure requirements. This isn't like mountains and mountains of paperwork. It's a simple FDA inspection before you start manufacturing, and then a requirement to follow that same inspection every other year.
Gotcha. You're also a co-sponsor of the Treat and Reduce Obesity Act, which would expand Medicare coverage for FDA-approved obesity drugs. Expanding Medicare coverage is not something Republicans traditionally embrace always. Why do you think it's important here?
Yeah, I think this is important because if you look at society as a whole, like we do have an obesity problem in our society. And when you look at the overall cost of healthcare in our society, we spend about 19% of GDP on healthcare, about $5.5 trillion per year. A lot of the cost associated with healthcare is a result of obesity. And so my belief is if we can reduce obesity in our society by any means necessary, we end up ultimately lowering the cost of healthcare and bending the curve as relates to federal government expenditures. We all have these friends out there, right, who've been on these GLP-1s, or at least let's just say that you say, hey, you've lost a lot of weight in the last 3 months. They're like, yeah, 45 pounds in 3 months. It's like, wow, what are you doing? Well, I got this new workout routine. I've been eating healthier. Sure, right? We know that these things work, and my belief is that as we get a few years down range, I'd be really interested to see what happens to the overall scope of our healthcare expenditures here in the United States. Are we still at 18 or 19% of GDP? Are we still at $5.5 trillion? Or as we start taking steps to reduce obesity in our society, do those numbers come down?
So on that point, in addition to this bill, the Trump administration has been testing a program that does provide more Medicare coverage for these GLP-1s for certain people who have obesity. How should success of these programs be measured? Are you looking at lower healthcare spending? Are you looking at better health outcomes? What should be the measure?
When you look at some of the results of the studies, I mean, you've seen that when people reduce obesity in their own lives, they have less chronic diseases, they have less surgeries, they have less time in the hospital. That should lead to a lower overall cost of healthcare in the United States. And so what I'll be really interested to see, and of course that takes a little bit of time, right? You lose weight today and then the results come over the course of the next 10 years. And so what I'll be really interested to see is what do our healthcare expenditures look like 3 years, 5 years, 10 years out. I mean, to me, that's ultimately what success looks like, is an overall reduction in the long-term cost of healthcare and health delivery to Americans.
So how do you balance that with what would be a pretty enormous upfront cost of expanding Medicare coverage? How do you balance that, especially when, sure, we could see effects in 10 years, but it could also take 20 years, 30 years down the line before we really see some of those long-term impacts?
Any long-term success requires an upfront investment. Right? If you want to go and retire, you have to make an upfront investment in your retirement. If you want to buy a home, you're making a big upfront expenditure. Long-term success in this country requires upfront investments. I don't think it's anything different with your own health. I mean, you talk about the long-term payoffs beyond 10 years. This is one of the reasons why when I was on the House Budget Committee, I led an effort to say, as it relates to preventative health measures, the Congressional Budget Office should be able to take a 30-year window and a 30-year look, not just the traditional 10-year look. Because you're absolutely right. A lot of these investments do take time to pay off, but when it comes to the health of Americans, we should be making investments, especially given the fact that one of the largest areas of growth, maybe the largest area of growth in federal government expenditures, is on healthcare. So if we can make some investments up front in healthcare to get long-term payoff and long-term savings, and by the way, also have Americans who are much healthier, I think that's a good thing.
And so who should qualify for that kind of coverage? Are you talking anyone with obesity, or should people with higher risk be prioritized? How do you think that should be decided? In
terms of the overall qualifications and who should be on medication, I generally have a preference for leaving those decisions between a doctor and a patient. I mean, I'm not an expert in that field. I think that the doctors who serve patients are the experts, and so leaving it generally to them or to healthcare experts to determine eligibility is where I would stand on.
But with like a federally funded program, something like Medicare, do you think there should be any kind of limits on who can access that kind of thing?
I think that's like CMS and the experts should be involved in who should access that. Again, I'm not a healthcare expert. I know that this is, from a broad perspective, this is generally the way I think we should go. I generally believe that we should have a healthier society. I genuinely believe that Americans should have more access to healthcare that can be preventative in nature as opposed to reactive in nature. That's my general belief. The nuances of how we get there and who qualifies, who doesn't, I mean, generally I would leave that up to healthcare experts.
Okay. So in addition to looking at expanded Medicare coverage, the Trump administration has also been working to make drugs, including GLP-1s, more affordable. They've pointed to their most favored nation pricing policy. They want Congress to codify it. Do you think that's the right way to drive down the cost of GLP-1s?
When it comes to the most favored nation status, I generally believe that it's not just about Americans paying less and taking a cram down. I think that other nations should pay more. I mean, other nations should have to pay their fair share so that we in America can pay less and so that we're not necessarily subsidizing the rest of the world. So the Trump administration's efforts to make sure that other nations pay their fair share and that they pay more, I think that's a good thing.
Okay, so would you vote to codify the most favored nations policy?
What I would like to see is I'd like to see the details. And I've been asking around what are the details behind how you could codify that. Right now we've got 17 or 18 separate negotiated agreements that are kind of in a bit of a lockbox that we don't know all the details to. So what I'm interested to see is how you would do that before I make a determination of whether or not I would support the codification. I want to know how you do it.
Okay, and the other thing, there's also Trump RX, which is another effort from the administration. Are you seeing meaningful results there, lower drug prices?
We are seeing meaningful results. As a matter of fact, if you pull the most recent CPI data and you look at the detail in the CPI data, what you'll find is overall, year over year, medicine, the price of medicine has actually come down year over year. In real dollar terms, we're actually seeing reductions in the overall cost of medicine here in the United States. So I think that the Trump administration's efforts to bring down the cost of medicine, they're clearly working. It's showing up in the economic data. It's showing up in the inflation data. So I think that's something that's really good. I mean, the American people have said that they want to pay less overall for healthcare. There's a number of different paths to getting there. One is some of the efforts of the Trump administration. Two is, as Americans, we've got to take responsibility and actually live healthier lifestyles. And that is also a good thing in the long term. So overall, it's working, and it's supported in the most recent CPI data that we saw come out in the last week.
Right. So we talked about GLP-1s now are one of those ways people are getting healthier faster. Everyone, it seems, is using them. How many members of Congress at this point do you think are on a GLP-1?
Who knows? As I look around at my colleagues, we do have a few colleagues that have lost some significant weight. A couple of those colleagues. So I'm an every morning in the house gym guy. I mean, my alarm clock goes off at 4:45 a.m. and I'm usually in the house gym by around 5:15. Some of my colleagues who've lost a lot of weight, I've noticed that they spent a lot more time in the gym. Some of them, they just claim to have a healthier diet. Sure, right? So there's a few of them. There's one actually, I'll tell you, there's one lobbyist here in town who's lost a lot of weight. And I said, you're looking pretty good. He says, yeah, the miracles of modern medicine are wonderful. Let me just tell you. So some people fess up to it.
Well, we do like to end with one fun thing sometimes. So I was going to ask you, what is your workout routine and who are your favorite house gym workout buddies?
Sure. So I'd say in the house gym, I typically go back and forth between on the treadmill and then a weight routine. But I'll also tell you, lately I've been working out with Mark Wayne Mullen. So Secretary Mullen, former House member, still comes to the House gym every single morning, and he runs a workout class in the House gym. It's about a 45-minute class, starts at 6:30 a.m. And I got to tell you, if you think you're in good shape, go work out with Mark Wayne Mullen, and you'll realize how out of shape you really are. I mean, the guy in a workout class, we were working out yesterday. Mm-hmm. I've never seen him sweat during a workout. And I'm like, how are you not exhausted right now? I mean, he is an absolute machine, and he's a fun guy to work out with.
Great. Well, thanks for that fun anecdote. We appreciate you being here. That's all the time we have for today. Thank you, Congressman.
Hey, thank you so much.
Please give a warm welcome to our View from the Top moderator, Eugene Scott.
Good morning, everyone. I'm Eugene Scott, and I thank you for being here. And we want to give a thank you to our partner for this morning, Partnership for Safe Medicines. All that we do here at Axios would not be possible without the support of our partners. So please join me in welcoming Partner for Safe Medicine's Executive Director, Shabir Ember Safdar, to the stage.
Thank you.
So glad to have you this morning.
Thanks for having me.
So we're here today talking about risk and regulation in the GLP-1 marketplace. Your organization, the Partnership for Safe Medicines, recently released a report that describes the emergence of compounded GLP-1 medicines as a parallel, lesser regulated drug supply. What do patients need to know?
Well, first, thank you for having this event with us. I would say that the footprint of patient safety endangerment across all the issues is largest right now in the compounded GLP-1 space. There's so many patients, hundreds of thousands of patients who are taking these medicines, and what they don't realize is that they are not FDA approved. They're made under different safety standards. In fact, the FDA specifically has to say that they are not tested, they're not tested for safety or efficacy, and not approved. And if you look at consumer surveys, Americans buying those don't even know that. So it's a huge, huge patient safety risk, and we are on par, and we've already seen some real harm.
So you point to specific legislation, the Safe Drugs Act is part of the solution. We have two members of Congress here today who care about this issue. But I wonder, what is the federal role versus the state level and regulatory actions that can be taken? And who can move fastest and have the greatest impact?
So pharmacy regulation is a joint project between federal and state regulators. And so I view the feds as having this important role of setting the boundaries and being able to enforce where they need to use federal powers to enforce. The FTC is pretty unique, and the FDA is incredibly unique. And then state boards of pharmacy, for example, enforce within those boundaries. So the feds set the tone, and then the states help execute inside the boundaries that have been set out by the feds.
So the GLP-1 shortage officially ended more than a year ago, yet compounded versions still make up nearly 1 in 5 weight loss injection prescriptions. How did a temporary emergency exception become a persistent workaround? And why aren't existing laws enough to keep patients safe?
So the reason that we still have what I would consider a ton of illegally and non-medically necessary compounded GLP-1s is because of a combination of simply willful disobedience of the rules and then a lack of clarity. The lack of clarity is cleaned up by the Safe Drugs Act, which is why we've been so ardent about supporting it, defining what is essentially a copy without clinical benefit, which you shouldn't be compounding. In terms of flouting the laws, one example is there's a 503B outsourcing facility. All of them learned last year upon a certain date in the spring that they were supposed to stop compounding tirzepatide and semaglutide. One of them announced this spring, a year later, that they were still compounding but had just stopped. Now, if I as a company got a notice from my regulator that I was supposed to stop and I kept doing something for a year because it made me a lot of money, I would expect to have some consequence. But there has been no tangible consequence beyond a warning letter for that company or any of the other ones who flouted the law.
So some advocates for compounded medications argue that tighter oversight could limit access and drive up costs for patients. How do you think about prioritizing patient safety while still focusing on access?
Well, Representative Yakym did a good job of talking about how safety shouldn't be a trade-off. And we at the partnership believe that access to an unsafe medicine is no access at all. Let me give you an example. Let's say I came to you tomorrow and said, I have this new car and that I've built that doesn't have seatbelts or airbags, but it's cheaper, so it's accessible to more buyers. We have reasons that we don't allow people to do that. And that's what's happening here, is that there's people who are being pitched deceptively that compounded medicines are cheaper without being told of the risk and without being told that it's not medically necessary.
There is an FDA meeting on peptides tomorrow. I know you're speaking at it. Can you tell us about the importance of this meeting and what some of your concerns are around what could happen in this space?
So what's happening tomorrow is that 7 substances, 7 peptides that have no human clinical data on their safety or efficacy are being considered to be added to the 503A bulks compounding list. The consequence of that is that all the wellness influencers you are seeing will immediately begin touting these as if they are healthy, have health benefits, even though there's no actual human clinical evidence that any of them do. We have a process that assures that drugs are safe and effective and of quality, and that's the FDA approval process. What's happening now is the wellness industry is attempting to circumvent that process by getting them available for compounding without doing the homework of showing that they're safe in humans, that they're effective, and that they're made to quality standards. The FDA's advisory committee should vote no on all 7 of those peptides tomorrow if they want to actually be serious about patient safety.
Indeed. Well, unfortunately, Shabir, we're out of time this morning. Thank you so much for joining us. And a special thank you to our partner today, Partnership for Safe Medicines, for helping make these conversations possible.
Thank you.
Thanks.
Please welcome to the stage Axios health tech reporter Brock Turner.
Good morning, everyone. Thank you again so much for joining us. I'm really excited for our next guest, but we're going to talk about how GLP-1 medications are rapidly changing the way we approach chronic disease care. Our next guest has spent his career caring for patients, really diving into this debate. So please join me in welcoming from the National Center for Weight and Wellness, Dr. Scott Kahan. Thank you. So, Scott, I'm really excited to chat with you about this. When we start a lot of our Axios articles, why it matters is right near the top. So I wanted to ask you very bluntly, why do GLP-1s matter, and why should we care about this conversation? Are these the chronic disease cures that many big pharmaceutical companies want us to believe they are?
Okay, so more broadly, obesity management matters. The majority of Americans have problems with their weight, and in the majority of those, it leads to further health problems, from hypertension to diabetes to sleep apnea and to even more downstream things over the years. So we need to address obesity. There's many ways to do that, and typically bringing different treatments together in an overlapping way can help manage it really well. And that includes diet, healthy eating, exercise, and so forth. But when that's not sufficient, and to be clear, the one thing I want to push back on what the congressman said before is sort of chuckling when someone says that they're eating healthy and exercising, that's how they lost weight, and assuming that it had to be a medication and not that. That's not true. Eating healthy and exercise is important for everyone, and even if it doesn't lead to losing weight, it's going to be good for their health. But for many people, that's not enough, and then we consider escalating to medications. That can include GLP-1 medications or other non-GLP-1 medications. With that said, by far the GLP-1 medications that are approved in the last few years have been more effective than what we had in the past, and they're very good medications. They can help many people to better manage their weight, to prevent or treat diabetes, in some cases to improve heart disease outcomes, and potentially other long-term health risks. I would argue that they're not cures per se. they help to better manage a chronic disease, and they're important in that sense.
Something that you mentioned earlier, like we've and compounding has been a big debate here, and we've spent a lot of time talking about it even today. And in my reporting, I've come across so many health tech companies that have spun up businesses around this. What do you make of those businesses, and is there a place for them, for personalized care? Because that's what a lot of them are saying.
Yeah, so I don't think we should put all this into a single box. There's a real value in these companies that have come around, either with telemedicine or otherwise, to try to scale up the approach to obesity, which previously had been very limited. There's exceedingly few doctors that specialize in obesity medicine, and generally primary care doctors and other non-specialists just don't have a background in managing obesity. So to be able to scale that up via telemedicine or otherwise, that is potentially a really, really valuable thing, and that has been really helpful for many people. On the other hand, when you're scaling up in a for-profit company, there's any number of things that can get in the way. And so there have been a number of studies showing that in many of these companies, the patients aren't even being seen by a doctor. They're simply filling out a form, and in many cases, the form is designed to lead the patient to the answers that give the company the ability to write a prescription. In many cases, there's not monitoring of medications after they're prescribed. So there's a lot of risks. And then, of course, in many cases, they are using compounded medications, mass compounding of medications, rather than actually studied GLP-1s or other medications. And so that's a real problem. It has only gotten worse, and it's important both for doctors to inform patients about these risks, and I think also really important for legislation to nip this in the bud to some extent.
Do most of these companies make money off of the individual prescriptions, or are they making money off of the wraparound programs?
So I'm not privy to how these programs work. I've consulted with a few of them. My understanding for many of them, they're making a lot of money on the compounds, selling the medication, which in and of itself is a conflict of interest, and they're also making money perhaps on the wraparound care.
And I know there's like a huge industry, a cottage industry that has spun up, like offering those sort of wraparound services. Like insurance companies will support that and maybe use that as a precursor to giving someone coverage for their medication. Do those programs work?
So there's a lot of potential good here. So again, as I mentioned, there's very few specialists in obesity, and very few general doctors have any background in obesity, in counseling for healthy diet and behavior change and exercise and so forth. And so some of these companies have come around. Noom is one example, and there's some others that contract with insurance companies to have a turnkey program for some counseling for patients and support for patients to help make healthy changes while they're on these medications. In and of itself, that's a really positive thing. I think a lot of the ways that it's been implemented is really challenging. So for example, I can't tell you how many times I have a patient and they are required, before getting a prescription, before getting any counseling from us, they're required to go to these third-party programs. And in and of itself, again, the third-party programs are fine. We have a dedicated practice with PhD psychologists and doctors and dietitians, and so it's making it both harder for them to get care. It's creating, in some cases, more barriers, and it's taking them away from dedicated experts to a third-party program, which is fine, but of only some modest value. So, both positive and negative, but it all depends on how you implement it.
And it sounds like is there room for regulation there?
I would imagine, but right now we're fighting against just this tide of sort of capitalism that has come into place to try to solve a big problem, but has created some bigger problems because there's lots of money sloshing around and very hard to get people in the right place.
I want to zoom out a little bit here. There's obviously a huge market opportunity, and these drugs come with a very high cost. So, what tools do you have in your toolbox to lower end user costs?
Look, I mean, as the congressman said before, there needs to be some degree of investment in order to improve long-term health. And so, unfortunately, obesity management is not an inexpensive process. It is done well. It's high touch. There's a number of specialists involved. Often there's a lot of talking and support and counseling, and that's just not cheap. And that's even besides the cost of medications or other treatments. So that's a challenge. And that again, I think, is where some of these companies have come in and brought something valuable to the table, where they have found some economies of scale and have been able to scale up a treatment that is otherwise very expensive on a one-to-one basis. With that said, the risk there is dumbing down the treatment and just simply doling out a medication or some magic diet or the like in hopes of doing something very cheap but ultimately not very effective.
And I know there's a big debate among like folks that I talk to, especially a lot of these like wraparound companies that we were talking about earlier. Folks like think that you can come off these drugs. Where does the science stand on that?
So what you're talking about is marketing. There's a lot of marketing trying to say that if you just come here, you can get off the medications, or you don't have to think about diet and exercise, et cetera. None of that is true. That said, the big picture is that obesity management is a long-term chronic process to manage a chronic condition. And so there's no easy way outs where you just do a diet and then that solves the problem, or take a pill and then that solves the problem. This needs to be managed over time. In most cases, people that go on medications and have a good outcome, in most cases, they need to continue using the medication or some type of medication. Otherwise, they tend to take steps backwards if they just stop it. Now, that's not universal. There's any number of patients that will be able to build a set of skills and an approach where they are able to come off the medication, or perhaps sort of de-escalate treatment to a less intensive medication or lower doses of medication. So there's a little bit of truth on both sides here, but without question, this is a chronic management condition that is not going to be cured, neither by a diet or a supplement or a prescription medication.
And I think that's a really important point, because there's so many different like misaligned incentives here. I mean, at the end of the day, kind of what you're saying is like, yes, these are high cost medications, but for a not insignificant portion of patients, you're going to be on them for a long period of time.
Indeed, and hopefully costs come down over time. We're already seeing some of the medications go generic, and we'll see that again over time. Let me also say, I mentioned earlier that there's both GLP-1 and non-GLP-1 medications, and while the most effective medications on average that we have today are the newer GLP-1s, we've had pretty good medications for a couple of decades. Several of them are non-GLP-1s, and they tend to be quite a bit cheaper. So there's lots of options here that don't necessarily have to break the bank, and certainly don't mean that we have to go to untested, compounded, supplements to try to bridge the difference.
Where do you think this compounding debate is going? Like, are you surprised that we're still having this conversation? I remember covering these companies at the Super Bowl last year when we were, talking about this and the Hims and Hers ad, and here we still are. Are you surprised we're still having this conversation around compounded?
If you asked me a few years ago, I absolutely would have been surprised. The way that things have evolved the last few years, I'm not as surprised, but it makes an absolute mockery of the field. And I think all the patients that struggle with obesity and weight management and weight-related conditions, to think that in other areas of medicine, whether treating patients with antibiotics or treating patients for hypertension or the like, to think that we would have mass compounding of substances that are not studied, that have no safety basis or efficacy basis, and just be doling them out broadly, I don't think that would ever happen. And that's what's happening here. It's not really fair to anybody. There's a whole bunch of people making money. That is what it is. It's not fair to patients. It confuses the heck out of doctors. They don't know what to tell patients, and it's not productive. It's not productive by and large in our society and in our healthcare field.
Hims and hers and like these other compounders though would probably put. I mean, I'm sure they would push back, and they would say, you know, we are offering personalized care that is able to, you know, we're able to address the symptoms that you might have, the side effects that you might have while on these drugs. I guess what's your reaction to that? Because like there are a lot of patients who are frankly happy with, you know, not having to, you know, face a doctor in person, not have to go through like that whole, you know, like in-person process. That obviously there are ways to improve the healthcare system. Like, I guess what would be your reaction to that?
Well, let's not conflate using dangerous substances with telemedicine. So telemedicine is potentially extremely valuable. I use telemedicine in my practice quite a lot, and I agree with you. That can be extremely valuable, especially in a field where patients are often marginalized, and it can be feel shameful to go to a doctor and put yourself out there to ask for help with respect to weight. So the value of telemedicine is potentially fantastic. The value of programs that can scale up treatment is potentially fantastic. But that doesn't mean that we should be making up these myths about compounded. I keep keeping away from saying that they're compounded medications. I don't consider them medications. Medications are approved by the FDA. They're studied for safety and efficacy. These aren't. And so something like the Hims and Hers that you mentioned, they're not doing anything unique to personalize these treatments. They're simply doling out these compounded substances and selling them to patients. In many cases, I don't even think they're necessarily saving patients a whole lot of money. I'll give you an example. Just so happens this past Monday, so 2 days ago, I had a patient come to me. She'd been thinking about a medication for a while, but had been hesitant. And finally, she's ready to start something. She's a very good candidate for it. And she did all her homework. So she came in and she said, you know, I looked online and I found that there's this telemedicine company, which I won't mention, that is where I can get it for, I think it was $225. And she said, should I do it? Do you want to write a prescription there or something like that? It turns out that it was a company selling compounded substances. And at $225, that's not cheaper than what she can get real medications, real GLP-1 medications for with a real prescription. So we discussed it, and she decided to get an actual real prescription. And it was 2 days ago. Hopefully it'll go very well. But that's an example that I see frequently where there's this myth that the compounds are also really cheaper, and they're not in my experience.
Dr. Kahan, unfortunately, we are out of time. Thank you so much for joining us.
Thank you.
Appreciate it. So we've had a really engaging conversation today, but we're going to wrap it up here with Representative Nikki Budzinski of Illinois. She has been at the center of so many meaningful policy debates, telehealth as well. Please join me in welcoming Congresswoman Representative Nikki Budzinski.
Thank you.
Thank you so much.
Good morning. Good to be
Morning.
with you.
So I wanted to start this conversation with where we left off the last one. It's around compounding.
Yeah.
Obviously, you know, for some patients, maybe it's more expensive, but for a lot of patients, they do feel like it is cheaper. So how do you sort of manage this, you know, protecting the intellectual property of pharmaceutical companies,
right,
but also managing like access, which in, you know, like in your district, there are like rural patches where, you know, obesity specialists probably not super available. So how do you juggle these competing interests?
Yeah, I mean, what I would say is I think the issue around compounding and the heart of it is
is really actually around affordability. I mean, I think a lot of folks, we did hear that there might not be some total big price differences, but in a lot of cases there are. And so I think that for patients, especially in districts like mine, I often talk about how the median income in my district is $55,000. So people are really feeling every push and pull, whether it comes to healthcare or housing or whatever. And if it is specifically with prescription drugs, if you can save even maybe $20 with a compounded pharmaceutical, a drug that mimics or is really a knockoff of the real deal, people are going to look to that option. So I think one of the overarching, I think, bigger points to me as a policymaker is that we need to bring down all of the different costs as it relates to healthcare, how we're looking at helping to save money, help to bring down some of these prescription drug costs. We've been making some good gains on that, but I think that there's more that can be done.
I know Congressman Yakym mentioned that earlier as well. So I guess where have we made gains? And where do you feel like we still need to make progress?
Yeah, I mean, I would credit the Inflation Reduction Act, quite frankly, on creating a program where Medicare can negotiate over a certain set of pharmaceutical drugs. The biggest one, insulin, at capping it at $20. I think that that's really a big step forward, but it's really just the beginning. And I think being able to expand that pool of drugs for Medicare, one of the things I think we don't talk about enough is Medicare. Yes, that's very important because that universe of people is so big, but looking at private insurance as well, how do we extend those same benefits on price caps to those on the private market? I think those are other ways that we can kind of make these steps toward bringing down costs. But we took a big step, I think, in the Inflation Reduction Act.
And I know a lot of these like GLP-1 companies have cut deals, with Trump RX and other areas, and they're even going directly to consumers. In some cases, partnering with third-party telehealth companies for this. Does that help bring coverage? Does that help bring prices down in your view, or is this something that just blurs the lines?
Yeah, I mean, probably won't surprise you when I say I'm skeptical of Trump RX.
Really?
But yes, shocking. But the reason for that is that people on Trump RX, they don't have health insurance. This is just anyone that can go on the marketplace. There are only very specific drugs on it. It's very unclear what kind of real savings there is in it. There's a total lack of transparency around what is provided, what's being offered. The people that couldn't just get, working toward getting on a health insurance plan might not be long-term benefiting from going that route rather than looking at something that's just purely off-the-shelf pricing. But I think it's a talking point, and I think it does speak to, again, I think the bigger issues around healthcare, being able to provide an affordable prescription drugs, lowering the cost of prescription drugs is something that I'm sure Rudy talked about. This is what Democrats and Republicans both want to be able to do. I'm sure we'll talk about PBMs, but I think that's another area where there's a lot of bipartisan support when we're looking at different levers that we can be pulling, again, to bring down costs. But I'm skeptical that Trump RX is really doing anything meaningful to get at the root of these issues.
I want to lean into that. I want to lean into where you feel like there is common ground, which it doesn't feel like there is a ton of in today's Washington. So I'm curious, where do you feel like there is common ground, and are there any specific areas where there's real momentum to be able to pass bipartisan legislation by the end of the year? We are in a midterm.
Yeah. Well, I want to give a shout out to independent pharmacists. And I say that because I think both Democrats and Republicans recognize we need to be doing more to support them and the pressures that they're facing with a lot of this consolidation that we're seeing in the PBM space. I represent Central and Southern Illinois, and in Southern Illinois, we have Southern Illinois University in Edwardsville, has a fantastic pharmacy program. I've done done a roundtable discussion with my local pharmacists to hear from them. And there is immense pressure. A lot of these businesses are family-owned businesses that are passed down, but they're struggling to stay afloat with the pressures that they're facing regarding pricing, the contracts that they're being kind of forced into with these PBMs. How do they continue to reach their bottom line? And so I think that's a very bipartisan issue, what we can be doing to support. It's why I'm on the Pharmacists Fight Back Act. You know, credit to Congressman Jake Auchincloss for really being a real leader in this PBM space. But, you know, Buddy Carter in Georgia, that's a Republican. This is, again, I think, a space where we can continue to make incremental progress. One of the things I think we need to be able to make progress on is spread pricing as it relates to PBMs, addressing the vertical integration issues. These are two issues in particular that, again, I think there's common ground on. Pharmacists Fight Back Act actually works to address. And again, overall, these are measures that are going to help us bring down costs for prescription drugs and head off, I think, some of these issues around compounding.
I do agree with you. I think there is, you know, PBMs have sort of drawn criticism from both sides of the aisle. But I don't want to be skeptical, but do you think there's actually like momentum to get that legislation passed this year?
Yeah, I mean, I'll tell you, the Pharmacists Fight Back Act is getting marked up today in ENC. And so I think that's a positive indication of a step forward. Again, I think that things from a public policy perspective in Washington, I'm in my second term, fourth year. I've already, it's very clear to me that it doesn't move as fast as we'd like it to. And certainly when we're talking to, when I'm talking to my constituents at home who are really facing an affordability crisis. I mean, it really is a crisis. Healthcare, I think, is at a crisis point. So the urgency, I'd like to see more of that, but I'm encouraged by some really common sense legislation that is actually making some progress.
A big part of this administration, at least through the first 2 years, has been around like price transparency, rooting out waste, fraud, and abuse. I'm curious, does price transparency, I mean, it feels like a step forward in some respects. Is it a step, like, do you think it's far enough?
I don't think it's far enough, but I think it is a very important step in the right direction that I think will shine a light on where we need to be really looking next. I think we have an idea of where we want to go next, but I think transparency is just incredibly important. The 340B program is a great example of another program. I think there needs to be more transparency within that. It isn't just within, within PBMs, which is certainly something. I'm a member, I'm the vice chair of policy for the New Democratic Coalition. One of the things we really lean into is the importance in all sectors of healthcare in transparency, accountability, but also competition. I think competition is something that we don't talk enough about, that I think with competition, that's why vertical integration is something that is a real problem when we're talking about PBMs and prescription drugs. But more competition in the healthcare market, I think, will overall help us in a lot of different ways actually bring down cost.
And I know when we're talking about these healthcare costs, so much of that sort of, like I know you sponsored the telehealth flexibilities, extending those. So much of that, especially in rural parts of your district, I'm sure critical. You see it. So I guess, how do you see that evolving? And like we're dealing with like unit economics where it is harder and harder to deliver care at scale in rural communities. So how do you, like what tools do you have in your toolbox to be able to help that?
Yeah, I think that's a really great question. It's incredibly important in a rural district like the one that I represent. We don't have enough OBGYNs in my district. We don't have enough. I mean, there's a primary care physician shortage that is a real problem, and it's only exacerbated in more rural communities. I've sponsored legislation to help look at ways that, from a student loan forgiveness perspective, if you practice in our communities for up to, I think it's 10 years, we can help relieve up to $200,000 of your student debt. I mean, we need to find different kind of common sense things that we can incentivize people to be practicing in our rural communities. But telehealth, while we're trying to figure that out and really train and recruit more of those specialists and primary care physicians and nurses, as well as a whole other issue as well, that healthcare workforce issue is tremendously large, but telehealth is that bridge. And I think it's not going away. I think, as we all know, it is a healthcare modality that has really now been socialized, normalized for a lot of people all across the country coming out of COVID. So I don't think we're going back, and I think we really need to use it as an additive, way to be able to distribute healthcare.
And I wanted to center that point, obviously to today's topic, GLP-1s. We chatted with, Dr. Kahan about just sort of how folks utilize that. Does it concern you at all that there are the shortage of in-person providers, and folks are clearly turning to telehealth, especially with weight management, because there aren't other options. Is that a concern for you, or is that just a reality that we have to understand and embrace?
Well, yeah, I think to me there are things that we can be doing to help people not have to make that healthcare decision necessarily, as some folks are going to need GLP-1s. But for those that might not, preventative healthcare is something that helping people, with weight regulation, helping them with a healthy diet. Another issue in my area are food deserts, when people are trying to make healthy, good lifestyle decisions. Sometimes when you live in rural areas and you don't have those options, that can also exacerbate issues. But I think looking at preventative medicine and preventative healthcare and what we're doing overall within the healthcare system to incentivize people taking advantage of preventative healthcare, I think can help maybe head off some patients from maybe necessarily needing the GLP-1s. Some will, but I think that's one way. Another way I think that's important to take a look at getting at that question.
Do you feel like there is bipartisan support, and what would legislation around that look like?
Well, on preventative health care, I think in order to do that, we need to make sure that people have health insurance and that they can get access to a primary care doctor. I think what we're facing right now is an ACA marketplace that needs to be stabilized, with premiums that are skyrocketing. As I know, have talked, I'm sure, a lot about the expiration of the ACA tax credits, and what we do know, people are going to be increasingly falling off out of the ACA marketplace. That's going to create a lot more instability within the marketplace itself. And then you look at, Medicaid as well. Being able to help people, again, maintain their access to their doctor through a robust Medicaid program is critically important if we're trying to protect and make sure that people have access to preventative health care. So that is, very top of mind of immediate things that we can be doing at the very least next Congress.
I wanted to zoom out quickly before I let you go. Biomanufacturing, really important in your district. I know you helped secure a $51 million federal grant for that, but it's not something that typically is making front page news,
right.
At least not that I'm reading. So why should we be investing? Yes, yeah, okay, fair. Why should we be investing more here?
Yeah, so I joke at home I represent still a corn valley because we use corn products, agricultural waste can now be reprocessed into yoga pants, but also alternative protein sources. I think this really gets to the opportunities that are in the broader bioeconomy, which is medical breakthroughs, pharmaceutical breakthroughs. I think the bioeconomy is linked to that. We're doing our own version of that in my district, utilizing agriculture, but that obviously those kind of investments in innovation and research is so critically important to the next opportunity of breakthrough in medicine. And that's why I would just give a shout out. I also represent the University of Illinois in Urbana-Champaign. So when we're talking about the bioeconomy, research, medical breakthroughs, we can't not talk about what's happening at NIH right now. And both the two-prong kind of assault, I would say, on NIH and what that will mean for medicine and medical breakthroughs, whether it's over 2,000 staff members that NIH has lost. These are experts in their field helping us with the next medical breakthrough. The thousands of NIH grants that we've also lost. So I connect all of that, the importance of NIH, the importance of research to the bioeconomy that'll help us with our next prescription drug breakthrough, pharmaceutical breakthrough in medicine, that'll help us cure cancers, that'll help us live longer, healthier lifestyles. These are the things that we need to be investing in. And sadly, right now, our federal government has really turned its back on those opportunities. We need to get back to that.
Congresswoman, we're going to have to end it there. Unfortunately,
Okay.
we are out of time.
Sure.
A special thank you again to the Partnership for Safe Medicines for helping sponsor this conversation. And thank you all for joining us this morning. Please join us for some light refreshments afterward, and stay in touch with us at axios.com/live. Thank you all so much. Really appreciate it. Have a great day.
Thank you. Thank you. Nice to meet you again.